High responders are, I think, a favorite topic for many of you. I do not really like to compare with cars, but some people do this. When you think of a fast car, then you have to be really careful when you drive the car, because if you push the engine too hard, you will have an accident. And so high responders, they need some special approach when you think in terms of ovarian stimulation, because of the very difficult dose-response interaction sometimes. In the title, it was mentioned hyper responders, but I think the more common term is high responders. Now, high responders, there is no strict definition of high responders. When you look at the large trials, then it is accepted that when you have more than 15 oocytes after ovarian stimulation, that you are a high responder. Now, how to predict this is, well, has been difficult in the past, but now with anti-Mullerian hormone measurement, it has become more easy to identify women with high response. Now, there have been well, studies performed by Ferring in the past, and I will mention briefly the MERIT study, where HPHMG was compared to recombinant FSH in an agonist protocol, and the MEGASET trial, where these two gonadotropins were compared in an antagonist protocol. When they looked at the highest quartile of AMH, then this was an AMH more than 5 nanograms per ml. So we can easily use this as a threshold for predicted high response. And antral follicles count is also possible, but this largely depends on the skills of the echographists and also on the quality of the ultrasound machine. Now, overall, women with high predicted response have a good overall prognosis. So we're not talking about poor responders who have a worse prognosis. These women have a good prognosis. But it's not all about prognosis. It's also, we have to think of side effects of ovarian stimulation, because we are talking about healthy women. We don't want to make them sick when we do ART in these patients. So they have an increased risk of developing ovarian hyperstimulation syndrome, as you know, and a lot of research in the past has focused on trying to develop the most safe protocol of ovarian stimulation in these patients. Now, we also know that these women also have an increased need for strategies to avoid ovarian hyperstimulation syndrome. And among these strategies, we know that cycle cancellation has been done. We know about the agonist, GnRH agonist trigger in antagonist protocols, followed by elective vitrification of embryos. That's also a strategy. Now, these strategies, although we commonly use them, not all women like to have their embryos frozen. They want to have a fresh transfer, because this reduces the time to pregnancy. Now, until recently, there has not been really much evidence of a specific gonadotropin that would be a preferential use in high responders, until recently. Now, when we look at the large trials that have compared recombinant FSH and HPHMG in a standard population, well, Ferring has done some RCTs, and I would like to focus on the most recent RCT, which is the MEGASET trial published by Paul de Vos in 2012, where these two gonadotropins were compared in a standard population. Now, the result of this study was clear. There was similar live birth rates, ongoing pregnancy rates when these two gonadotropins were used. So there was no superiority of one gonadotropin to another. However, in retrospect, when the data were analyzed in more detail, it was found that in the quartile of patients with the high AMH, which is more than 5 nanograms per ml, a higher live birth rate was found when women were stimulated with HPHMG. So the difference was significant in retrospective analysis, 42% live birth rate per transfer after HPHMG and 26 after recombinant FSH. Also, when they looked at the safety profile in the MEGASET trial, they found that the women who had had HPHMG had a lower risk of early OHSS and safety interventions. So this was an interesting observation, but it was a retrospective observation. And as all of you know, in scientific research, in endocrine research and reproductive studies, we need prospective data to be able to confirm what we see in retrospect. So the prospective study that was designed in 2017 has recently been published in Fertility and Sterility 1 month ago. The first author is Craig Witz from Houston IVF in the United States of America. This is a prospective randomized controlled trial in 31 fertility clinics in the USA, where a non-inferiority design was accepted, which means that a difference of 12% in ongoing pregnancy rate was accepted as non-inferior. And based on this assumption, a sample size calculation showed that 275 women had to be recruited in each group. So in the HPHMG group and in the recombinant FSH group. Now, who did they include? They included high responders, predicted high responders. So we are talking about young women between 28 and 35 with menstrual cycles which were accepted to be a little bit higher, like longer, up to 45 days. So you already feel and you already know that among these women, some will have the diagnosis of PCOS. However, the testosterone levels had to be normal, and they also had, they could not be obese, and they needed to have a serum AMH that was above 5 nanograms per ml. So these are predicted high responders with a good functional ovarian reserve, willing to accept single embryo transfer. So women with hyperandrogenic PCOS were excluded, and also women who had previous miscarriages. So the design of the study was such that on day 6, after a daily dose of 150 units, the hormone levels were analyzed, and also an ultrasound scan was done, and it was possible to adjust the dose as needed. So if there was hypo-response, then the IVF doctor was allowed to increase the dose in his patient or her patient. The standard trigger was HCG, and it was also acceptable that if more than 30 follicles were visible on the day of trigger, that a GnRH agonist trigger could be given. Now, there was standard luteal support, and the embryos were cultured until day 5. And on day 5, all blastocysts had a biopsy for pre-implantation genetic testing. Now, this is something I would like to explain in more detail. So a fresh transfer was possible after the biopsy, which means that the embryo was transferred without knowing the result of the genetic analysis of the embryo. The result was only known later. But all the blastocysts were biopsied for PGT, which means that the other blastocysts that were not transferred were cryopreserved for future use in subsequent frozen embryo transfers. Now, the primary endpoint was ongoing pregnancy rates in the fresh cycle. And the secondary endpoints were also quite interesting. The OHSS rate, the cumulative ongoing pregnancy rates after transfer of the fresh blastocyst and subsequent frozen blastocysts, and also, last but not least, early pregnancy loss in the fresh and also in the frozen cycles. So the fresh IVF cycle was the primary focus, but the extended research design included up to 3 frozen cycles, 6 months from randomization. So we are going to look at fresh results and frozen transfer results. Now, looking at the baseline characteristics of the patients, these were similar, age was similar, BMI was similar. AMH, so we're looking at women with high functional ovarian reserve with a median AMH of 7.8 nanograms per ml, high AFC. And when you look at the stimulation results, then you see that the stimulation duration was slightly longer in women stimulated with HPHMG. These women also needed dose adjustments more frequently after day 6, so the dose had to be increased. And this means that they had a mean total dose that was higher than the recombinant FSH group. The number of oocytes was significantly lower in the HPHMG group, 7x less than in the recombinant FSH group. And approximately 2/3 of women in both groups had a fresh embryo transfer. The other ones had a freeze-all strategy. Now, looking at the baseline estradiol levels, there is not much to be mentioned about this, but on day 6 of stimulation, you see already that in the HPHMG group, the average serum concentration of estradiol was lower in the HPHMG group compared to the recombinant FSH group. So we are looking at different gonadotropins, which have a different impact on the follicles up to day 6. And then the dose was increased, the stimulation dose was increased in more women in the HPHMG group. And this is why at the end of stimulation, the differences between the two groups in estradiol levels were not so high. So as I already mentioned, 7 oocytes less, but nevertheless, the ongoing pregnancy rate per cycle start was similar in the two groups. And if you look at women who had a fresh transfer, then the live birth rate per fresh transfer was also similar, was around 50%. Now, interestingly, women who had a fresh transfer after HPHMG had less early pregnancy loss. So this was even almost significantly different. So this brings us to the extended study where the 6 months of frozen embryo transfers were added to the analysis. And there you see that the live birth rate after all frozen embryo transfers in the HPHMG group was 63% compared to 50% in the recombinant FSH group. But what is really significant is the difference in cumulative early pregnancy loss. So after frozen embryo transfer, you see that the risk of having a miscarriage using HPHMG stimulation was significantly lower compared to the recombinant FSH group. So this was, I think, a very striking finding. Now, on this slide, you see that although when we look at the cumulative live birth rate after fresh and frozen transfers, the live birth rate was similar in the two groups, this result was achieved with fewer embryos in the HPHMG group and also fewer transfers and fewer embryos. So we are looking at similar outcomes with fewer embryos. So this is something that needs to be looked at in very much detail. Now, safety scores are also important, and what we already knew from the MEGASET study in the standard population, so the normal responders, and well, all groups of response, we see in this specific RCT in high responders that the OHSS rate was significantly lower in women who had HPHMG compared to recombinant FSH. And so early OHSS was also significantly lower. So in conclusion, I think that I'm not sure who is drawing all these fancy things on my screen, but in predicted high responder patients, ovarian stimulation with HPHMG provided a good safety profile without compromising efficacy. So the ongoing pregnancy rate was non-inferior after HPHMG compared to recombinant FSH. The cumulative live birth rates were also comparable, with fewer transfers and a lower number of transferred embryos to have the same outcome. The higher response in terms of oocyte number with recombinant FSH did not give any more pregnancies, but was associated with a higher risk of OHSS and a higher incidence of OHSS. And one of the most striking findings here was that the early pregnancy loss rates were reduced in HPHMG group, and this was not because these women had a higher incidence of euploid embryos. No, not at all. So the PGT results were have been analyzed in great detail, and the aneuploidy and euploidy rates are exactly the same in the two groups. So it's not the chromosome abnormalities that could explain the difference in early pregnancy loss. So several questions remain and require further study. What is the mechanism for the different stimulation profile? We see that the estradiol levels are lower on day 6, and we see that the stimulation is faster and also slightly more aggressive even in high responders who use a recombinant FSH. And what is the mechanism of the reduced cumulative early pregnancy loss after HPHMG? Now, we have to bear in mind that this RCT, the MEGASET-HR, included high responders, but also women with polycystic ovary morphology, which means at least 12 antral follicles in each ovary with a standard ultrasound machine, and with a more advanced ultrasound machine, more than 20 antral follicles per ovary. And also women with polycystic ovary syndrome type D. Now, type D means that the androgen levels are normal, but this study cannot give you any information about women with other PCOS phenotypes, which means hyperandrogenic PCOS phenotypes. They were not included. Now, let me just expand for the last 2 minutes on the differences in stimulation response. We know from previous study, and I think a very important read is the Jeppesen paper, GCM 2012, that the antral follicles, they express more FSH receptors than LH receptors. The FSH receptors are in blue and the LH in red. But as the follicle becomes bigger, and we're talking about a natural cycle here, the LH receptors become the majority, and the FSH receptors are less presented. And this also means that the FSH dosage doesn't have to be so high in the end of stimulation, because there are almost no FSH receptors in the end. It's all about LH receptors in the end. So if you see this, then you can understand why the two molecules that have been studied here, HPHMG and recombinant FSH, have different actions on different sizes of follicles, where the recombinant FSH has a very strong and powerful action in the beginning of stimulation. And also we're talking about different FSH molecules, of course. Now I'm going to skip this one because it will take us too long, but I would like, as a final slide, I would like to refer to a very interesting slide from the paper of Johann Smits, published already a long time ago, 2007, in Human Reproduction. This is a study where in women who were treated with an agonist protocol, HPHMG versus recombinant FSH, it was found that women who had high levels of HCG in the serum had a higher, significantly higher number of top quality embryos compared to women with less HCG in the serum. So the HCG content is probably associated with oocyte quality. And I think this is a very interesting finding where that can give us probably some more information about the results of the MEGASET-HR study. Thank you very much.